Hello, everyone. It's nice to see everyone rolling into the webinar. Um, as people start piling in, I will kick off our formal proceedings. Firstly, hello, thank you for coming and joining us tonight on a webinar about MBS compliance, a hot topic here at the AMA. I'm Danielle McMullen. I'm the Federal AMA President and a GP in my day job, so this is certainly an issue close to my heart, as clearly all of us who are dealing with the MBS every day really do want to do our best and understand the intricacies of what can really be a complex system at times. I'd like to acknowledge that I'm joining you from the lands of the Yuggera and Ugarapul people today and pay my respects to their elders past and present, as well as acknowledge that we're joining from traditional lands right across the country tonight and pay particular respects to any Aboriginal or Torres Strait Islander members joining us this evening. Before we get into the official stuff, a strong reminder that AMA 25 is coming up in August, which is our annual conference. It's going to be in Adelaide this year from the 1st to 3rd of August. And for anything that you didn't catch tonight, there's another session about compliance and the MBS at conference. But as a particular thank you for coming along tonight, we're also offering a 20% discount to anyone who's attended tonight's sessions. So keep an eye on your inboxes for a follow-up email about that, and we'll share that discount code. And then also a heads up that our next webinar in a couple of weeks' time is on cyber fraud. And we know that cyber security is another really big issue for doctors in practice out there. And so that'll be on the 24th of June. So keep an eye on your inboxes for that. Bit of other housekeeping. Please note that tonight is being recorded and we aim to be able to share that recording with all of you and more broadly afterwards. And so now into the meat of things. Obviously, as a membership organisation, doctors and the work that you do every day is at the heart of everything we do at the AMA. Obviously, we do the big picture advocacy and trying to improve the health system more broadly, but also we try and offer member supports and make sure that you've got the tools and resources you need to be able to focus on delivering patient care in a system that is complex and at times difficult to navigate. So tonight it really does bring me great pleasure to have some of the Medicare compliance team with us to help work through some of the current issues in MBS compliance and give you a bit of a heads up and tools and resources to be able to better focus on patient care. So tonight we've got David Nott with us, who'll be running most of the webinar. And David leads the compliance, education and engagement part of the MBS or Medicare. Really pleased to have him with us. And there's a team also behind the scenes off screen ready to help with some of the Q&A session so that we can get to as many of your questions as possible. We did get a number of questions in advance, so hopefully a lot of that is covered in the webinar itself, but there will be an opportunity for Q&A. I'll direct you to use hopefully the Q&A function that helps us keep a better eye on the questions coming in. So please, as the presentation's going on and then later when we open up to questions, popping those into the Q&A function and we'll address as many of those as we can, noting that types give you an early heads up, as I'm sure David will as well, that specific questions about interpretation of MBS items often do need to be taken offline for specific advice, and hopefully tonight is a really more general discussion about MBS compliance more broadly and some of the activities happening in that space and how it all works. So I will hand over to David and thank you so much for taking us through tonight's presentation.
Thank you, and really happy to be here. I always say this is the best part of my job. I'm a teacher by training. I've spent roughly 1/3 each of my career working on MBS policy, PBS policy. I reviewed the MBS twice. I reshaped with a team some of the GP remuneration through level B and C early in my career, negotiated community pharmacy agreements, set PBS prices, negotiated with big companies, negotiated with the guild as well through CPAs, and So I'm not born and raised compliance, but I am a compliance person now. One thing that I would say, I think as a sort of starting comments, if there's one thing that the compliance profession, if I put it that way, has very much in common with doctors, it's prevention is better than cure is one of our big mantras. And that's why I really enjoy these engagements. It gives us an opportunity to get out and talk to you who are seeing what's happening on the ground, who are seeing the difficulty of navigating a very complex MBS. When I started working on the MBS in 2006, I think it probably had about 3,000 items, and it's now got over 6,000 items. So Danielle said, we can't offer an Ask MBS service, and there is an Ask MBS service if you have detailed item questions about can item 291 be claimed with item 305 or that kind of thing, or on a blue moon as you're walking down the road. So we can't necessarily go into that level of detail. We do need to make sure that we give you the right answers. We, like everyone else in the department, certainly in the policy areas, we're guided by legislation. We want to make sure that we give you the right answers. But we do enjoy talking about compliance too, and hopefully at a minimum, what you take away is something that's interesting for each of you and something new. So when you see me do this, it's not because I'm doing whirligigs or anything else. It means, Maggie, let's go to the next slide. So Maggie. So this is our agenda for the presentation. There will be a Q&A. One thing I also want to mention, safe space for us. This is a really important safe space for you. Ask your questions in the Q&A. There is no silly question. We want to hear what you want to know. We want to see if we can answer it on the day. If we can't answer it on the day, we'll answer it afterward if we at all can. So please pop your questions in. Where possible, I'll try and cover some of the content as we go. If not, then we can cover it in the Q&A session that happens after. So this is our guide for what we're going to go through tonight. There's a little bit of general information. There's certainly some specific information as we go. You can keep going, Megan. So this is just the context of what the Benefits Integrity Division covers in terms of our work. So we are a compliance unit within the Department of Health, Disability and Ageing. We are not the only compliance unit. There are actually a number of different compliance units that look after compliance for hearing programs. They look after compliance for vapes. They look after compliance, obviously, for these programs that we manage, Medicare Benefits, Scheduled PBS, Child Dental Benefits, and PIP. There's quite a bit of compliance work that's done across the department, but obviously we take care of some of the biggest programs in terms of more than $48 billion in taxpayer expenditure. And we do have an interaction, if you're curious, and I've seen some questions on it, with the National Health Reform Agreement as well, because that's a document that enables public care and public hospital care, and it has interactions with the MBS through rights of private practice. And my immediate past job, well, one of my immediate past jobs before coming to my current role was working as the Director of Public Hospital Compliance, where obviously we spent a lot of time working through issues around duplication of payments. Not everything is done within our department. That's important to point out, and it may help guide some of your questions as we go through the night. We do not, or at least not in the last 16, 17 years, it happened while I was in health, we do not do the processing of MBS and PBS claiming, and there will be a bit of mention of PBS claiming as we go, not much. Our department does legislation, we do policy, we do provider compliance, and those things fit quite well together in terms of good compliance work hopefully should feed into good policy and vice versa. And then obviously we have Services Australia who do the payments themselves. They have the payment engine and they sort out some of your questions and queries in terms of access to HPOS, in terms of getting your Medicare claiming done. And they also deal with non-provider compliance matters. So where there happens to be, for example, patient fraud, that's a matter that goes to Services Australia. Just wanted to talk quickly about something that most people here will have heard about, the Phillip Review and the 23 recommendations that was made as part of the Phillip Review. I'm going to presume that most people know the background of the Phillip Review and that it sort of shone a very sharp lens onto Medicare compliance and raised concerns at the time around the outlays, that were going towards potentially non-compliant Medicare billing. You no doubt all have your own views on the numbers that were touted at the time, but what's been done since the Phillip review, the government did respond and decided to put in place a task force, and the task force has crystallised the work and the recommendations that have been made by the Medicare, the Phillip review, into 8 main areas. And this really demonstrates, before I get into what is the compliance work that we do in terms of some of the more direct interventions, this talks about the work that we do that you're not necessarily going to see a great deal of, perhaps until it comes to fruition. So we work closely with other departments, Services Australia and others, and within our own department on governance. We are working on policy simplification. Now, again, I'm certainly not going to make any promises around the number of MBS items that there are, and it is a very complex system, and that reflects the complexity of clinical care. But wherever possible, we do want to try and make it easy to be compliant by default, if I put it that way, where the system and what we provide assists you to be compliant without having to worry about knowing all the ins and outs. Prepayment controls goes to that, and early detection and disruption is some of the work that we've been working on as well. Provider support. There's one that I particularly want to come back to. I'm a big fan of Maggie, who's on the call with us. Her team developed the Medicare handbook. Many of us within the department, the Medicare provider handbook, many of us in the department contributed to that, and many peak bodies, including the AMA, provided comment and insight into the kinds of details that should go into that. And that's a really valuable thing that I think is hopefully good for all new practitioners. Medicare systems, better use of data and legislation. These are essentially things that we're always interested in improving. It's always going to be a concern, and I've been audited, I think, 12 times in my career by the Australian National Audit Office. It's always a concern when you're being audited that you want someone to have a reasonable basis on which to have a conversation with you. So they've done some analysis, they may have some concerns, and they understand a little bit about what's going on before they come to audit you. And that's a very strong theme within what we do in Medicare compliance. And I'll come back to that. So this is the broad brush of how we identify non-compliance, and we're continually refining this, and you'll have questions about what kinds of tools we use. We'll use any useful tool. We will partner with other departments. We partner with Home Affairs. We partner with the National Health Funding Body, for example, in terms of understanding some of the duplication between public hospital payments and the MBS. We're continually refining our tools in terms of data, intelligence, and the information that we take in. The information that we get from peak bodies, I certainly wouldn't want to downplay, is incredibly important to us, because it's that contextual information that lets us understand, is there something here that looks unusual but actually is quite reasonable? So I won't read all of the lines across the page. The decision to act is a very considered one, if I put it that way. So we don't just work straight off data. We get a signal. Sometimes that signal is sent in via tip-offs, which of course you're very welcome to send in as much as anyone else via the link that you'll see below, and there'll be links that we can provide after. So you're very welcome to report if you have concerns about Medicare billing, and that includes PBS or child dental benefits as well, or PIP. And we'll then assess what's going on. We will get some insights from our own medical practitioners who are internal. We have many more medical practitioners per capita than any other part of the department for that very reason, and understand as much as we can about what's going on before we make a decision to act. That being said, many times, since we have a relatively mature compliance system, many times we are looking at issues that have really persisted for many years in some cases, and we know quite well. And I'll talk about some of them as we get into the meat of the presentation, the interesting stuff around what are our current concerns. So we might move on. So if you've been to one of these presentations, You will have seen one of these pyramids. This is probably a slightly different version of a pyramid. I won't labour the point on this pyramid. It gets brought up every single time. Sorry to anyone who has seen it before and has heard the spiel. So this has been reshaped since we've been working on our provider compliance strategy for 2025 to 2030 into something that's sort of, it's essentially a two-parter, where on the right side, we're talking about what we might do in relation to the level of concern that we have. And on the left side, which isn't necessarily always correlated with the level of concern, is the level of sort of the attitude to compliance. So you might find, for example, that deliberate non-compliance doesn't always lead to criminal concerns or prosecution, even though it's level with that level in the pyramid. It can be at different levels. I will tell you, I think you've probably heard this before if you've seen the pyramid, where we really like to spend most of our time is down the bottom, where we can encourage knowing what's going on, knowing, as I think Antonio from PSR would say, probably your 10 to 20 most commonly claimed MBS items, which for many clinicians is going to be the vast majority of what you do, knowing them really well, knowing their explanatory notes, knowing the permutations, and knowing what's acceptable in terms of compliance and not. We go to the next one. So on this slide, I'm going to quickly talk. I heard mention, and there might be questions about this, I haven't seen them yet. I heard mention of overseas claiming and letters. I think that's going to be something that we'll probably want to talk about in the Q&A, if not here. We will from time to time, particularly where we get potentially a larger scale signal, we will send out targeted letters, generally of two types, where we think there might be something going on and we want to get in early and try and educate and try and correct if there is non-compliance happening that maybe people don't know about, people weren't entirely aware, and do that prevention education. And similarly, semaglutide letters, so the prescribing of semaglutide is another example. All compliance, before I sort of go into the next levels, all compliance is fundamentally question and answer. And so we encourage you, if you do get something from us, first of all, you can get any help that you wish in terms of professional help outside of the department to go through the journey. We won't give you recommendations. There was one pre-submitted question around, for example, should someone use a medical indemnity insurer? It's not my role to say. I'd probably say ask the AMA if someone asked me that directly, but you can get all the help that you wish. We don't mind talking to medical indemnity insurers. We don't mind talking to lawyers. That's our job. We don't feel offended if you bring a lawyer. We're very happy, and we actually want you to have as much support as possible if you need it through the process. So at this level, it's mostly self-reflection and looking at your billing and trying to assess what's going on. If everything is fine, then it's a voluntary process and you don't necessarily need to respond. If everything is not fine, consider submitting a voluntary acknowledgement of incorrect payments. So we go to the next. So audit gets a little bit more formal. There's a little bit more legislation that surrounds audit. I have an audit dad joke later if we really need to tell one. So audit, again, is a question and answer process. All of these processes, other than the targeted campaign, targeted letter, they all build in natural justice. So that's where we ask you questions. We want to hear back from you. What are your answers? We want to examine your answers because we are auditors. And we will form conclusions. And you will get an opportunity to comment on those conclusions. Sometimes they may not be entirely correct. Sometimes there's more going on that we don't understand from your first answer. What I say in terms of any audit that I conduct is it's really useful, first of all, to have a conversation if we at all can. And secondly, it's useful to hear a story. Often the story tells a lot more than just a document that you think is the best response. The document is always useful. We want the evidence, and that's what we're going to examine. At the end of an audit process, many things can happen. They can close. There can be no further action. There can be some suggestions. Look at this part of your claiming. Consider whether you want to make changes. There can be debts raised. And that's, I guess, part of the process when it comes to compliance. Peer review. This is probably the one that you hear most about, and sometimes it is intermingled with audit and even some of the court activity that is undertaken. Peer review is a process undertaken by departmental medical practitioners. It looks at comparing people to their peers in terms of their activity and looking holistically at their claiming. So yes, there are percentiles that are considered in the peer review process. Yes, if you're involved in a peer review process, you will get an invite to an interview generally. And that interview will be with a departmental medical practitioner, and you'll have an opportunity to describe what's going on. It doesn't always result in any outcome at the interview level. And this department, importantly, for anyone who wasn't aware of this, we have our own views, obviously, but we do not determine inappropriate clinical practice. That is a role for the professional services review, where this process can refer if the concerns persist beyond the interview stage and the discussion. So I'll come back to that with an example a little bit later on if we go to the next. Oh, I'll do an example now. I've got the sliders here. So this is the process. I've gone through this in a little bit of detail, and we only have limited time. A lot of this detail is on the website. Hopefully a lot of it is known to you. Like all of our other processes, I'd like to say, and I think Antonio would like me to say on behalf of PSR, there is a huge amount of natural justice built in so that you have the opportunity to say exactly what's going on. And again, it doesn't always result in an adverse outcome, but it's important to engage in the process actively and assist our departmental medical practitioners to understand what's going on. And in many cases, as with the 80-20 rule and the 30-20 rule, which I'll go into a little bit later, there are many, many people who will never get to see this process because it really does look at the sort of top echelons of activity, if I put it that way. And then fraud. So fraud being criminal fraud, fraud being deliberate activity targeted at taking money out of the system, potentially, generally takes the criminal route. So we would take this activity to court, and it is obviously a court that determines whether the activity merits any type of response, sentencing, anything of that nature. Fraud investigations are very important to the department. They're not very common, and I'd like to think that, you know, as we've seen in the literature, very, 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 very few people engage in fraud, but it's a very, very important part of non-compliance for us to target and deal with to ensure that, because ultimately, and I think this would resonate again for people who are listening, we are a function that is about making sure that Medicare money gets spent appropriately so that there's more money there for the good clinical activities that you undertake. And we know and recognise that the vast majority of what you do is compliant, is great clinical practice, and is providing great value to patients. And that's important to keep in mind. So there was one question that came through in the pre-questions around, I submitted some items, one of them got through and it shouldn't have got through. Why didn't Services Australia reject that payment? It's a good question. With an MBS of 6,000 services, we would love for every permutation of potentially incorrect claiming to be picked up. Sometimes it's not a good thing to try and pick it up anyway, because it really is a matter of judgment that can only be made by a clinician. One thing to keep in mind is simply, if it goes through and gets paid, that doesn't necessarily mean it's met all the legislative requirements. It's important always, if you're sending through the billing, you are confident that the billing is correct. And I might come back to this when we talk about the potential corporate influence in terms of some of the billing that occurs, which is my pet area of interest at the moment, corporate compliance. So we released the Health Provider Compliance Strategy 2025 to 2030 a short while ago. Those are the broad objectives. I won't read them out. It really details on this page what we might do, and I've already talked about those. So we'll go to the next one. These are the areas of greatest focus for us at the moment. They may change. There is a mention of PBS, so I know this is an MBS seminar, but I do want to talk at least briefly about PBS and prescribing. Specialist and consultant physician claiming, bulk billing, which, to use a term, I'm not sure if we coined it, it's a bit of an unusual one, moiety, so multiple payments occurring where there's bulk billing, but there's also, for example, membership fees, inappropriate claiming of PBS medicines, opportunistic billing. I'll go through these in a little bit more detail and give you some live examples. These may change from time to time. For example, we're making some good inroads into open and uncertified PBS claims. But these, like when you hear from the ATO says, we're going to take a really good look at the amount that's been claimed for working from home, for people who happen to be doing so. So consider that very closely when you submit your tax return. This is like that. Have a think about this, and obviously claiming MBS services while overseas does feature, and I'm happy to talk about that as well. Oops, so we've gone to PBS, but I did say I was going to talk about it briefly. Prescribing at the moment, prescribing and telehealth, particularly working in and looking at corporate compliance, is a very strong area of interest and concern for the department. I've said it, I think I said it at the RACGP conference. Telehealth has the potential to be the best and worst thing that happened to us, certainly to this department in terms of compliance. It can do many good things. It can do some not so good things depending on the influences over the claiming. So this is a general prescribing is important. Please make sure you get it right slide. We do have some, I guess, fairly current concerns, and you've seen the 730 report, which I'll come back to. Hopefully you've seen it, all versions of it. And not all of the activity that is of concern at the moment in the prescribing space is funded PBS activity. But unfunded activity has a tendency to become funded activity, and I think we would all like to see that there are some strong controls around patient access. I might think that after 20 plus years working in the health department, that I'm great at just going and getting what I want, and a doctor doesn't need to consider that, but that doesn't make it true. So it doesn't mean that I should be driving the care decision or the prescribing decision. Inappropriate practice. So this is our line that leads potentially to practitioner review and PSR. If you haven't heard about the 80-20 rule, maybe it doesn't affect you very much. If you haven't heard about the 30-20 rule, certainly encourage taking a look. And really, as I said, in most cases, it's very rare, and it's only the top echelons of activity that tend to come into view. And it's not uncommon when the top echelons of activity do come into view and we think, wow, that practitioner actually is in the top 1% for claiming of 2 different items. It's not uncommon that when we engage with that practitioner, particularly during COVID, there are some pretty good and obvious reasons for some of that activity to occur. Unfortunately, sometimes there are not so good reasons, and that's why this function exists. You'll all be well aware of the large injection of funds that's going into bulk billing over the coming years. And so I think this has been an area of focus for us for a while. It becomes an even more sharp focus for us in coming years. Where you bulk bill a patient, you accept the rebate as the entire payment for the service. You can charge for vaccines that are not funded by another mechanism of the Commonwealth, state, or the PBS. Anything else such as membership fees, various types of fees, we've seen many of them, and I fielded many questions about them personally. They are not allowed if you are bulk billing patients. That's how bulk billing works. It's a version of public care, if I put it that way, where the patient has to pay nothing more, nor any other system. So this is a general slide, but it goes to some of the issues and concerns, as I said, that are sort of closest to my heart over the last sort of while. We deal with businesses on a range of axes in terms of potential non-compliance. Many of you would know that we've been looking at rents paid around pathology for quite some time. with the concern fundamentally that the higher rents that we are seeing paid sometimes might be fueling kickback arrangements, which are not acceptable under the NBS. We see quite commonly, particularly I think since COVID, that there are corporate structures and policy arrangements that are being set up within companies that drive and pressure providers to meet targets to potentially bill inappropriately. One of the things that I'll comment on here, but I'll probably come back to later in the presentation, is I guess know your rights as a practitioner. Your billing under your provider is yours, and you have every right to see it. You have every right to examine what's going on. You have every right to check it, and we encourage that it should be checked before any NBS claim is submitted. And then, of course, the patient decides model, which is mentioned down the bottom, where someone was writing scripts every 4 minutes. And I think that was every 4 minutes of a 24-hour day. So I won't say my hat is off to that person. I think I'm impressed that anyone could manage to push that many scripts through at all, but not impressed in a good way. We've probably seen some recent examples of use of AI. And use of AI, I think, is great in healthcare. There's been many good examples. I've seen some of the products. We know that AI is susceptible to making some somewhat fundamental errors of judgment. So it's absolutely a great tool for ensuring that you can get really simple work done a lot faster. What we are concerned about is you should not be setting up an AI or a script to make all the decisions for you, which we saw quite a bit during COVID, and we're still seeing persist now, where again, the sort of patient-driven clinical activity where a patient gets on a website, fills in questions, and the script bounces them around to the various parts, and maybe there's no review at all of the request for care. Maybe there's a limited review. Sometimes there's no clinical relationship between the doctor and the patient. These are all things you as clinicians know don't lead to good care and that we would naturally have concerns about. Opportunistic billing and upcoding, again, potentially pressure driven. I'm certainly not going to say that all the activity we see is driven or even overseen by corporate. So just to be clear, there can be profit driven motives or other motives. I guess just have a very good look at the arrangement that you're in. And that goes to the last point around loss of autonomy. I won't ask anyone to put their hands up, but I've done a lot of work talking to public hospitals, talking to practitioners in public hospitals, various sort of informants around there, including peak bodies. I hear all the time, I don't know what's going on under my provider number. It was built into my contract that my provider number needed to be managed and used for me when I was working at this company or at this hospital. It's not a requirement from our perspective. And it is a concern that as soon as that provider number gets away from you, it's a bit like giving away your credit card, except the credit card was given to you by the government. So we strongly encourage that you have a good view of what's going on under your provider number. I almost feel like we just need to defer this one to the Q&A. I'm sure there's going to be lots of questions about it. So it's a long-standing principle of the NBS, and you will have some questions about this, and I do understand them, having worked in NBS policy for quite some time. It's a long-standing policy that we only fund services that delivered and received in Australia. We understand that this raises questions, and I received one at the RACG conference last year around, but what if the patient's overseas and I need to do some quick telehealth? And there will be examples of, I guess, arguments that you could make that funding should work in a different way. What I would say in my position in relation to that is I work in compliance and I work with the legislation that we have right now. And that's the basis on which we approach the issue. So if you want to talk to our teams around what we've seen in the data and through data matching in terms of homes of fair activity and travelling, then we can help you with that. If you have a case to make around whether this rule is a good rule, that's a case that's best made through your peak body to the policy area of our department rather than this one. This is an area of persistent activity. Specialist and consultant physician claiming of 110s, 116s, 132s, 133s. I was there when 132 and 133 were introduced. And if you're a psychiatrist, 291, 296. If you're a geriatrician, your items, which I can't remember the numbers, but I think they're in the 300s. It was an expectation that when those items were developed, that they would be fairly standalone, at least to start with, that you would do your 132 and not, for example, claim a 133 on the same day or the next day. We do see that. That's pretty interesting because what's there to review in terms of the plan being used and rolled out if you're reviewing the activity the next day? So we encourage you to think very carefully around the correct item to use. It's probably a 132. I'm sorry, I'm talking MBS item numbers. I wasn't going to do Ask MBS. It's probably a 132 and then a 116, for example, as opposed to a 132 and then a 133, an immediate review. You can absolutely see the patient as many times as they want to see you, and there are items there to bill for the activities that you undertake. You can't always bill Medicare. That goes back to the overseas item. Sometimes Medicare can't fund a service. That doesn't mean that you can't charge for a service. It's probably an important point to make privately. So this is a small little bit of text, really big, interesting issue. I think I saw a question on public hospitals. I might just quickly open a chat. Duplicate payments, as many have very rightly and understandably said. I think I last heard this at AMA Victoria get together. This is an issue of doubling up of payments that tends to result from the way the MBS and the way that the NHRA and state health and hospital systems are set up. One thing that's important to keep in mind here is even though it is an issue of state and Commonwealth payments overlapping and realistically probably overfunding a service to the point where the taxpayer is overpaying, there is still a provider in all this. So that's why we talk to you about duplicate payments. It is an issue that still has some roots at the provider level, particularly in terms of some of the ways that people may have been brought up to understand payments work, which diverges from the way they should actually work. So an example of that is you have an episode of care in a public hospital, and then you have components such as path and DI that somehow get billed to the MBS despite the fact that it's a public patient. Realistically, that's probably going to be a duplicate payment. I might not answer that question yet, but if we go to the next. Some places to go. I want to spruik again, the Understanding Medicare Provider Handbook. Every new practitioner should read this, I think. We can obviously iterate and improve on it. There'll be things that you may learn or that we may need to change over time, but for the longest time working on the MBS, I would hear over and over, there's nowhere I can go to get that fundamental learning. That's what this is. It's not perfect. You will still have to talk to Ask MBS to ask some very detailed questions about item combinations and other things, but it is far better than what we had. So please, if you haven't already, have a look at it. You'd be surprised, even if you're a very experienced person in this area. I've worked in and around Medicare for 20 years. There's things I learn when I open up something like this. Medicare compliance website. I won't go into detail. So this is where we house our fact sheets and other things that you may see distributed from time to time, including on team care arrangements, chronic disease management items, and various other things that tend to be hot issues. MBS online is great. I know it's a very rudimentary looking website. I know it can be a bit hard to follow. Please look at the explanatory notes. So we had at least 2 to 3 questions that were sent in beforehand, which I could answer just looking at the explanatory notes for the items. So that's a really important resource. And we do try, even with 6,000 MBS items, to give you as much detail as you could possibly need through the various avenues in the MBS book itself, We will release fact sheets and other additional information as required, but we do try and fit all that information, if we at all can, into the descriptors and explanatory notes. And it's the descriptor at the end of the day which reflects the legislation in most cases that you need to adhere to. And last but absolutely not least, ask MBS. It's a highly valuable service. It can answer more of your detailed questions than we can, as I said tonight. And if you're in doubt, just ask. It's useful to do so. You may have used an item 1,000 times and you think, I'm not sure if I've been using that correctly. Please ask. They are an independent outfit. We obviously talk to the Ask MBS team, but they are set aside away from the compliance area because we want and need a tool that you can use to receive information that is not immediately about, whoops, you misclaimed that, you need to fix it. It is that sort of avenue where you can safely ask questions. Some tips for compliant billing. Hopefully everyone understands the term clinically relevant and how it applies to the MBS. That is the test that ultimately is applied through the practitioner review and the professional services review stream. It's not tested strictly through other pathways. So when we send you an educational letter, or when we send you a targeted letter asking you to review a schedule of claims, or we send you an audit letter saying, please review this schedule, we are not examining your clinical decision-making. We leave that to the departmental medical practitioners. We are trying to examine what occurred and whether the money that was paid should have been paid. So please consider whether the service is clinically relevant. Please have a look at the item descriptors and the explanatory notes. Please consider the complete medical service rule. This is not a very, yes, the descriptions of an item on MBS Online can change over time. We understand that you can't keep up with MBS news necessarily, but that's a good function of peak bodies, that they can keep you apprised of GP items are changing over the next little while. You should have a look at item 23, for example. So absolutely, they do change over time. Keep an eye on them, but again, peak bodies do a really invaluable piece of work there in terms of keeping practitioners advised of whether things are changing. So all MBS items are complete medical services. And I was trying to think of a good example for this, because I used to work in ophthalmology and orthopedics and lots of things that start with O. I did optometry as well. I did things that didn't have an O in them, just to be fair. I never did oncology, if anyone's wondering. So items are complete medical services. What that means is you might have, and this particularly, or certainly was the case in orthopedics, you might have items that are reasonable subsets of another item. In the GP context, I would say you could argue that if you're doing a level E service, then you've hit all the time barriers to do a level A, B, C, and D. You're not allowed to claim an A, B, C, D, and level E item because the complete medical service was the level E, which is the item that best describes the service that you provide. So claim the one item rather than multiple items that describe subsets of the activity in one item is probably the way that I would paraphrase the complete medical service rule. Good administrative and clinical record keeping is important. That probably doesn't need much labouring. I'm sure you hear this all the time, including from your indemnity insurers and other people. Do your own audits, or set someone up to do your own audits to understand just occasionally, is the billing looking right? Does it seem to reflect the activity? Is there anything going on here that I might need to look at and actually modify within my practice, or whatever your setup may be? Obviously, if it's a hospital, it's probably a different concept and maybe you need to talk to the administrator. Delegates is a good one as well. Like passwords, delegates and claiming agents and other things can be a bit set and forget. Anyone who's got access to your provider number, again, it's that credit card example, credit card given by the government. And if you don't know that person anymore. They're not involved with your practice. They're not associated with you. Think about whether they should still have access. My whirly gig's not working. Oh, it's working. You can submit a voluntary acknowledgement of incorrect payments. We shorten that to VA. So that's our acronym that we tend to use if you ever hear us talking in acronyms. So you can submit a VA. It doesn't need to be prompted. You don't need to receive a letter from us saying, hey, what about your overseas claiming, or this, that, or the other, claiming of this particular item. Anytime you identify in a self-audit that there is incorrect claiming, you can submit a voluntary acknowledgement. And a couple of case studies before we go to Q&A. It actually look like we have a huge number of questions yet, but we'll see how we go when we get to that section. So on audit's factual assessment, we look at evidence. We had tip-off about potentially inappropriate billing of multiple MBS initial consultation items. So this is your example, item 110 or item 132, often inadvertently misclaimed, I think, where people claim 2, 3, 4 item 110s within a 12-month period without a new referral. Audits aren't cyclical, but we do tend to pick up things that have been issues before from time to time, if I put it that way. So we are always reacting to the live environment in compliance. Sorry, I'm answering one of the questions as I go. We're always reacting to the live environment, and the live environment at the moment is quite different from before, where there's more telehealth. There's probably more concerns about the clinical activity and the level of clinical input that's being put into services, etc. That's probably driving fewer audits in some circumstances and more, for example, of the professional review type activity. So we analysed the data. It appeared that the services were non-compliant. We undertook the audit. As I said, this is a multi-step process, not really detailed here, where we'll write to you, we'll ask you some questions, we'll ask for your review, we'll consider those answers. We may go back and forth a number of times trying to understand and talking to you further. And as we go, we'll start to form some conclusions. And if the conclusion is there's non-compliance, then we may raise a debt. But in this case, it was actually a voluntary acknowledgement where through the audit process, the practitioner understood or came to understand that there was incorrect billing and decided that they would rectify it themselves. And that's perfectly fine. We are not about raising debt. As I said, we'd actually prefer to spend almost all of our time doing education and prevention. We will raise debts if needed. So I don't know if there's any psychologists here, but this is one example of practitioner review ultimately leading to PSR. I won't read out the example other than to sort of briefly brush over it. The practitioner was very highly ranked in clinical psychology for the number of services, which we do look at. We do look at percentiles where the practitioner sits, and if you're in the top, 1%, 2%, etc. The clinical activity was very high. The hours being worked, if you sort of mathed out, which we do, if you mathed out the amount of time spent per item, you thought, this practitioner's working an incredible amount of hours per day. And then the outcome was that the case was referred to the delegate. The delegate was concerned they may have not have met the requirements, and the practitioner was referred to the director of PSR. One of the things to highlight here is this will normally only occur if it appears that the practitioner is doing something that's clinically inappropriate, but hasn't accepted or admitted, as the case may be, that might be the case. It is not uncommon, as a sort of juxtaposition, it's not uncommon that a practitioner realizes there's something incorrect going on, says, look, I can correct this, give me some time to work on this, and they'll get a 6-month review period, which is mentioned there. And at the end of the 6-month review period, we see that the incorrect claiming has been fixed, which is great for us. It's not the case not the case here, and it's not always the case. So often when things do go to PSR, it's about where do we land with the intervention and the practitioner? Did the practitioner form a view that they were fine? And in some cases they do, and they go to PSR, and PSR looks at the case and says, yes, we agree, through the panel of peers. So none of this is automatic. None of this is the department forms a view, therefore a bad outcome occurs. I think that's just about the end of our slides, Maggie. Oh, now we've got one fraud example. We often find when it comes to fraud, and I won't talk about PBS in great detail, PBS is slightly different. We probably find that the practice owners tend to be the sort of predominant fraudsters there. We find it not uncommon that receptionists get involved in fraud on the MBS side, or if not, it might be your practice manager. It's certainly not always practitioners. There are, as you can see on the right side, there are sentences that are applied. There are reparation orders that do get applied. That one was over $3 million. These are fairly uncommon, but they tend to involve a large amount of money. And unfortunately, the reality of fraud is once someone starts conducting fraud, getting involved in fraud, often it's quite hard to stop them. So unfortunately, we do have to pursue a criminal route and get the courts involved. All right. We've got time for some Q&A. So I know Naren has been, Dr. Naren has been curating these as we go. So I might just pick up the last one from Danielle, and we can go from there. So how do we do an audit? How would a provider know items are being billed under their provider number without their knowledge? Is there a way other than local practice software? That's a very good question. So how we do an audit, we assess tip-offs and data over time, and we tend to pick up on themes. So for example, the item 132, 133, 110, 116, that's a fairly common theme. We find sometimes that people are being claimed for on the PBS side if they're deceased, and we have various other audits that we've tended to conduct a few times over time. There's two answers to the second question. And so when we conduct an audit, we collect all the information together and we do our own assessment of data, and we have that informed by our own internal clinicians and then by peak bodies in most cases as well, depending on the size of the audit. If it's a one-person audit, we may not go to a peak body and say, does this seem like a legitimate concern? But in most cases, we will go to the peak body and say, what do you think might be going on with claiming of this item? We're seeing some real spikes here. We're seeing some very significant variance from peers, et cetera, et cetera. So we collect all that information together and we put together a schedule of data. And the schedule of data is not a schedule saying every single item in this must be non-compliant. The items in it are items that we're concerned may be non-compliant. And we'll give you information on that. And we're happy to expand on that if you ask. What do you mean by potentially this is non-compliant? The second question, how would a provider know items are being billed on their provider number without their knowledge? HPOS is the answer. I know people are going to go, oh, no HPOS. There's another answer to this, which is please manage your provider number very carefully and make sure the only people who have access to it are those you trust implicitly. So I would hope even if there's someone billing unexpectedly, you would know that they might bill under your provider number, if I put it that way. But you can always go and assess your own claiming data through HPOS. And it doesn't just require the local practice software. I'm just looking through chat questions. Our audit cycle answered that one. Use the Q&A function. Is it allowable to bill a 110 9 months after a 110 is, we're getting into advanced MBS territory with this question, but I will answer it. Is it allowable to bill a 110 9 months after a 110 billed under the same referral? In general, if nothing else has changed, no. if the patient has, and this is all in the MBS, so I'm going to paraphrase it. Please don't take these as exact answers. If there is a new course of treatment and a new referral, then a new 110 or a new initial consultation, which could be a 104, can be claimed within that 12-month period. Anywhere we can view claims under a provider number, pretty much answered that. Don't think that's a question about overseas claiming. We understand, again, if I put it this way, I've been audited 12 times. Pretty much every time I got, we think we're going to audit you, it set me back on my heels. It's not a fun experience. We do try and provide, where possible, some of that forward understanding of what might happen through peak bodies. Sometimes the peak bodies can't necessarily communicate with you when we've talked to them and asked them questions, because we may not have made the decision to do anything. And we might even, after asking some of those questions, say, well, we don't think this is an area that requires non-compliance or compliance activity. We understand it's sometimes a surprise when you get these letters. We understand it sets you back on your heels. We have a friendly team who work in the provider education intervention section, or early intervention section, I should say. They're happy to have a conversation with you. And I really encourage that. If you're ever not understanding what's going on, you can give us a call. You can get in contact and ask what's going on, ask for a little bit more detail.
I think it might be worth there flagging that we have been trying to work over the years at improving that education and early intervention content and manner. Like some of these, do you maybe want to expand on how what people talk about as nudge letters, really how you guys view those in terms of the level of compliance that they are? And because I know the AMA has been working with your department over a number of years on how do we get a heads up, as you have done tonight, about kind of areas that might be on the radar for the next 6 to 12 months, plus then having things like the wording of the nudge letters being as calm as possible, although it's still distressing for people. And there's always learnings along the way. I know this time I've certainly had a lot of feedback that people would have liked to know what period you were looking at for some of the travel stuff, so that people could conduct their own mini audit and be better able to do a VA. But maybe just expanding on kind of what is a nudge letter and how does that fit into the compliance landscape?
So nudge letters sit at that level, which is, we think there could be non-compliance, but we suspect it's probably unintentional, and you may even be completely unaware that there was potential for a compliance issue here. We understand they tend to be some of the most controversial simply because of the number of people who tend to get them. We've been working very closely with peak bodies, including the AMA, obviously, over a number of years, really, certainly ever since I've been working in compliance, to try and get that good balance of wording that says there is a potentially genuine concern here. We'd really like you to review what's going on. It is a voluntary process in terms of the response. Now, one of the things to understand in terms of a voluntary process is if the concern is reasonably serious and we conduct a voluntary process and get no answer, we may have to escalate, particularly if we see what looks to be persisting behaviour in terms of the data that we're seeing. So we encourage you to respond, but it is your choice at the end of the day. And it's an informed choice that we encourage you to take. The person who's looking at 20 claims over a 1-year period, obviously we and that person are going to view that claiming very differently to someone who's claimed, we've asked them to look at 20,000 claims over that period as potential concerns. So there is always that balance in our decision-making and our consideration of what's actually going on here. And sometimes it may just be really down here in terms of the activity, just think it's probably worth a quick look. And sometimes it's more up here of, we're still not sure how much of this could be wrong, but we think a reasonable amount of it might be. So I won't go to the item number questions, because I think I've probably done enough Ask MBS for the night, but anything about billing of 141, 143, 133, 132, have a look at the items, have a look at the descriptors, have a look at the explanatory notes, ask MBS. You should be able to glean the answers for these out of the explanatory notes in particular. Is it worth informing Medicare if there's a change in my practice, like I do more longer consultations? No, you don't need to tell us. We understand and we accept that many practices specialise more in longer consultations. They'll do so because of socioeconomic reasons, because of the age of the cohort they're seeing, etc. And we don't have within the department a threshold where suddenly you've done too many level Ds if you're a GP or whatever the item may be. That's not how peer comparison works. We will look around at what's going on within the profession, but we will, of course, examine the area in which you're working. And sometimes it'll be you have an aged care home really close to you and you're providing a lot of service to there and the patients are really in need, maybe because they haven't had a GP who was able to be there in the last couple of months. All kinds of things can be going on. You don't need to tell us about a change in circumstances like that. Keep good records is obviously the overarching thing that we would say about all of these things. If you're doing long consultations, you've probably got longer clinical records and many more comorbidities that you're dealing with. Echocardiogram question. So there's a question in the chat about echocardiograms, which I won't sort of respond to in detail, but sometimes if billing is unusual, it will get referred to an officer for an assessment. That can be on a range of reasons. Sometimes that can be because the charge itself is quite high. Sometimes it can be for other reasons within the Medicare rules. So I can't give you what's going on. If you get those kinds of messages, you can certainly inquire with Services Australia. Question about regional variations, which again, I'll respond to quite briefly. We look at regional variations. We understand that if you're working in Mackay, your practice billing is not going to look like someone who's working in urban Brisbane. And that's taken into account through the process if there is any concerns, particularly around potential inappropriate practice. We look at it too for the other activities that we do, of course, just to be clear. Procedure is done in a public hospital. Can aftercare in private rooms be claimed? Generally not. There are all kinds of rules around providing services and care in public hospitals. You can be seen, for example, as an outpatient privately post-discharge if you get a referral from a GP. This is one of the questions I wanted to answer anyway. If you get a referral from a GP to then go back and see the specialist or consultant physician. Aftercare of public care is covered in public episode funding in ABF. It may be a separate episode, but it is a general expectation, if I put it this way, when you're admitted for an episode or a procedure, the aftercare is covered as public unless you elect actively to change your status to private, which a patient can do, but it is a patient decision. Unfortunately, sometimes we do see decision was not made by patients. So that was one of the questions that came in prior to the webinar. There's a consultant physician who has asked me as a GP, can I get a referral so a patient who's already been seen in the outpatient setting as a public patient can go back and see them as a private patient? Is that legal? It is. It is legal to ask anyone for a referral. It is, we hope, and we certainly encourage the patient's choice whether they wish to be public or private. So it is an expectation of the National Health Reform Agreement that someone gets a referral if they're going to see a privately operating practitioner in a public hospital in the outpatient setting. But it is a decision process to make a referral, and it's a decision process for a patient whether they wish to be public and or private as well. So we would hope you have that conversation, or certainly that the specialist does, around how do you want to fund this? It's a very interesting area and one I've been talking about with states for, I think, 6 years now. Co-claiming, Amelie, not entirely sure what your question is specifically. Co-claiming generally can be okay, depending on the items and depending on the circumstances. We do find that we see items that are co-claimed on the same day, which just realistically, it seems unlikely someone could have met all the requirements for both items. Good example being 132 and 133. I have seen examples of someone claiming the creation of a plan and then the review of a plan on the same day, and you just think, what did you do with the plan? Did you implement it? What are you reviewing it for? So there are obvious examples of pairs where it's probably not going to be kosher if they're co-claimed. But there are examples for, and one of the questions that came up in the pre-questions, can I claim creation of a mental health plan as well as an item 23 on the same day? Is that going to be okay? The answer is it might be. If you meet all the requirements for both items and the services are clinically distinct, then you might see a patient for one reason, maybe early in the day, maybe just before, and you claim an item 23 because that's the descriptor that you fulfill for that service, and then you go ahead and do the creation of a mental health care plan. The 110 9 months later was the earlier question, so getting your referral would be generally the answer. Have a look at the explanatory notes for item 110 and all the initial attendance items would be the answer to that. Won't try and answer the specifics of where you go in HBOS because it's just not going to be possible in this webinar. We can always follow up through the AMA with further details after. Ooh. And again, item specific. So Emily, when it gets to that level of detail of can I claim this item with this item, really useful to submit through to Ask MBS and they'll give you some advice around whether it's commonly seen or not generally considered to be okay. Have we just about covered everything? Well, there was a public hospital one I might go back to. Oh, I think you answered that, Naren. So if a public hospital uses a clinician's provider number to bill, despite the clinician not being away, who's liable? So Naren's answered that, consider closing your provider number or, making it inactive during the period while you're away. We do conduct audits where it involves public hospitals or other interventions, and it is not uncommon. I'm not saying it is going to be an outcome, but it's not uncommon that the public hospital ends up being the party that makes payment of a debt because the public hospital or its administration, for example, is the party that's ultimately responsible. So it does happen. And much as we say your provider number is yours and you should take very good care of it, that's not to say that we can't raise debts against other parties if they incorrectly use your provider number.
And that's a relatively recent change, isn't it, David, or a strengthening of that? I feel like we did some pretty strong advocacy in that space some years ago now, but within my working lifetime, that to really amplify how important it was for practitioners to know that there was potentially a shared debt recovery option for practitioners that might have been unduly pressured to bill in a certain way. Now, obviously, our advice to members is the same as yours, that your provider number should be protected at all costs and your billings are your problem and are your responsibility. But that shared debt recovery scheme was certainly a positive for doctors out there to have some reassurance in those circumstances where billing was done without their knowledge or consent.
Yeah. So shared debt recovery, I think was very important. Really interestingly, I think it was really important to introduce, it sent a message as much as anything to people who are managing provider numbers on other people's behalf that you can be held responsible. It's not a provision that we have to rely on very often because commonly when we have that conversation, the public hospital or the business or whatever the case may be will step forward and say, all right, I will manage this payment. So we don't actually have to very often split the payments between the practitioner 50% or the business 50%. But I think it's a really important provision to have there so that people understand we will levy debt against the party that should pay. And that can be a conversation, and it can even be a contested conversation where you say the business did it and they say you did it. And we can work that through as opposed to just defaulting to you, for example.
There were a couple of questions that did make it into a Q&A session that, apologies, it only worked for some people tonight. The first one was, what are the commonest billing problems areas that you see for general practice in particular? The key things.
There's a few, and the AMA would probably know them as well as us. I think what I've seen in the last 20 years, which is actually really when a lot of the care planning items got introduced and sort of bedded in. Care planning items tend to be the ones that are more difficult to understand and get incorrectly claimed. So those are the ones to really look out for. So 721, 723, 2710 for mental health care planning. I'm hearkening back to 2007 now. Look out for those. Certainly, in terms of the next question, look out for what your nurses or other people are billing as well. If someone does bill incorrectly while you're away, well, then that may need to be repaid, would be the answer to that question. Moiety, that term, which I probably don't love, to be honest, but that term that we use for bulk billing, but also attracting other fees, such as membership fees, and telehealth are probably the two other GP areas that I would highlight. We understand that many GP practices are implementing various arrangements to try and manage the cost of care. That's very understandable. When you bulk bill, you accept the rebate as the whole payment. Don't ask for other payments, please. And telehealth is, as I said, it's an area I think could keep me gainfully employed for many years to come, and many others. A very good thing for clinical care in Australia, but also an area of risk for people that, particularly some businesses, I think, are promoting very heavy use of telehealth. And sometimes that's getting away from the best clinical care for patients.
And yeah, and I think the one on like the 10997s is an interesting one because it maybe strays into the policy versus compliance question of an item number, because it's topical with the recent overseas travel one, where it's an item number that's billed under the practitioner, under the doctor, but is conducted by the nurse. And actually the MBS is kind of silent on whether the doctor needs to be on site at the time or not. So kind of how's that nurse supposed to know whether the doctor's in country or not? But is that more of the policy itself hasn't kept pace with the world and we need to advocate on that side, or?
Certainly from my perspective, as some of these questions have started to come up, I think you're right that we need to now take a look at some of the older things where first there was supervision in the MBS, then we started to have the concept of remote supervision. I think it was actually item 16400 that really brought that in to start with, which is obviously not necessarily a common GP item, and then it sort of proliferated beyond there. We need to understand supervision better and understand what was intended by some of these items. So I think they are good things to discuss for the policy area, because at the end of the day, we will go with what the legislation says, but there are certainly some understandable questions people ask around, well, telehealth is here now. What does supervision really mean in that context now?
And I expect on the chronic disease stuff, it'll be music to your compliance ears that they're doing away with the team care arrangement messiness, and that at least hopefully the new items, which shout out to everyone online who's a GP to be aware that CDM items are changing in like 4 weeks. So be across the new item numbers and descriptors as they come out. But there's much less box ticking and bureaucracy and red tape with them. So hopefully, David, that makes your job a bit easier too.
Music to our ears, as you say.
Now flick back through the chat again and just see if we've missed anything in particular. So yeah, that the question about kind of how to do the little mini self-audit from a PRODA perspective, HPOS perspective, the department will get back to us, or Medicare back to us, so we will distribute that to everyone who's here tonight. And I think there's a question in rooms. I mean, obviously reviews, Fernando's getting a reply. Now, remembering obviously that specialists can refer to other specialists, so you could potentially get it. I have seen on occasion where the ED refers to a non-GP specialist, but obviously that only lasts 3 months. And as a GP, we would prefer being looped in on care. So even if you got the referral from the ED specialist, looping us in on a letter makes us happy. Not that that's an MBS question, but thought I'd throw it in there.
Actually, there's a specific rule in the National Health Reform Agreement which is purely about that, I think. And it says patients cannot be referred to the private outpatient setting from an ED. And that is purely about the patient is public when they go to an ED, at least in a public hospital. And if you want them to be private, then they should go back and see the GP, first of all, for continuity of care. And second, hopefully, so there can be a bit of discussion around how should this be funded.
Interesting. That's a good flag we might have to have a think about because, yes, with the scarcity of public outpatient clinics, I expect that might be an area that's not quite always happening as it should. Excellent. Look, I think that's probably hopefully most of the questions covered. And I think, David, you went through the ones that you got ahead of time. And just doing a last little flick if there are any big giant ones that we missed. But I think we'd covered a bit of the overseas claiming, which I know is everyone's current shock and awe, but it was going, are you able to share, do you know what time period was under review during that so that people could go do their own little mini audit or?
In front of me, it'll be a year that we picked, but I'll have to go and get it and come back to you.
We can get back to people with a bit more information on that because I do know it's helpful to be able to, when you get even a nudge letter, some of us that are quite type A and then kind of get an information letter, it's hard to be told that you've potentially done the wrong thing, but not being able to even check your own findings to know whether you did something or not and fill in the VAs. So we do at the AMA really try and help feed some of that back, but also at the same time balance that with making sure that these are really educational letters and not a hard-hitting compliance. I know that I got a fair bit of feedback that people wanted a list of the items that they had been accused of misbilling, but then I know actually that if you'd gotten that list, that's a much heftier form of compliance and an educational nudge. So sometimes it is intentionally vague to try and make sure that this is about education and it's not actually Medicare trying to get that money back. There's a recognition that some of this was either inadvertent or mistaken, or a rule maybe that we didn't all know about. In changing times with more telehealth, for example, I think there was quite a fair bit of lack of awareness that this was even a rule in the MBS. So on that one in particular, we are continuing to work just to reassure people watching with David and his team and across the MBS to get as much info as we can to you. But it's always that balance. I don't want them pushing on you guys harder, like on members harder than they need to, unless there's actually something going wrong. Look, it looks like we are coming towards the end. As Ebony has just posted in the chat, there is a bit of a survey which we would really value if you can complete, just to see what you found useful, what other topics you'd like us to cover in these webinar series. Hopefully tonight has given you more of an understanding about how compliance in the MBS and Medicare works and the layers of compliance activity, and really highlighted the focus that David and the whole team have on that education and prevention is better than cure mentality, which certainly we would agree with. I think my takeaways from tonight were that billings are our own responsibility and to really know your own billings. But also if you get a letter or an audit, not to panic, but to breathe, seek help. You can contact us at the AMA or your MDO for that professional assistance if you need it, but just taking a second to think through it. And just hopefully you all know that we're also there at the AMA working for you behind the scenes to both on the nitty-gritty of everything down to the wording of some of these letters. As David can attest, we do give feedback on small things such as wordsmithing, but also the bigger things like their areas of focus and the process itself. And then we are also the ones that try and change the rules. So there was a little bit of discussion about that today where there is changing models of care and the MBS may or may not really still be fit for purpose in our modern environment. Our role at the AMA is to help advocate for you and build a health system that lets you get on with the business of doing care. And sorry, before my voice completely gives out on all of us, I just want to thank you, David, in particular, for coming along tonight, and everyone else for your attendance and for sticking it out. And really hope to see you all at our next webinar. Thank you, everyone.
Thank you all. It's a pleasure.
And thanks, Dr. Naren, in the background, in particular, the questions.